Next, I will call Dr. Sanyam Bajimaya, who will be talking about management of retinal detachment after VR procedures. Dr. Sanyam Bajimaya.
Thank you, AIOS, and thank you, Ava ma'am and chairpersons. I'm presenting on management of retinal detachment after primary VR procedure. I do not have any financial disclosure. Recommended retinal detachment, the incidence is 6.3 to 17.9 per thousands. And in our Asian populations also, the myopia and the age is one of the factors where we are getting more detachments. Cataract surgery, post-cataract, if there is any complications, even simple cataract surgery is also one of the risk factors for retinal detachment, which induces posterior detachment and subsequent consequence of retinal tear. And if there is any history of trauma and family history. So there's a rising trend of myopic retinal detachment in Southeast Asian and South Asian countries. So when we come to the management, one of the most important thing is the detachment patients, 50% will never get happy. So we need to have a very adequate counseling. We need to have a very good documentation from our side, including all paperwork, black and white documentations, fundus photography, ultrasound. So this is really sometimes we get into the legal problems. So we need to have a proper recording systems and EMR, medical recording system. And also there are options like pneumatic vitrectomy, so pneumatic retinopexy, buccal vitrectomy and combined surgeries. So many options are there, but sometimes I will come across the case directly to one of my clinical case back in 2021. She's a 65 years old female and she is diabetic and she is hypertensive and she was on blood thinner. And she had a history of blurring of vision in both eye, and when we did a retinoscopy, she was wearing a very high myopic glasses on, and she had these issues of diabetic macular edema, both subretinal and intraretinal fluids, and there was a traction which is called as vitreomacular traction. So with this, seeing this scan, then we first try 2 doses of injection Avastin. So after injections, the swelling and the macular volume slightly reduced, but the traction was persistent. And since she was 60 plus and having some cataract, so we planned for doing cataract surgery. And we combined the cataract surgery with pneumatic vitreolysis. That is, at the end of the surgery, we inject a 0.3 ml of 100% of C3F8 gas. So this surgery has been done for her right eye, where there is extensive vitreomacular traction, even though the diabetic macular edema has been reduced. So this was a cataract surgery, so I will slightly fast the surgery. We implanted the Alcon IQ lens, and we injected 0.3 ml C3F8 gas, and lastly, intracameral moxifloxacin. So this was a macular OCT after cataract surgery and pneumatic vitreolysis. The VMT is completely gone, and the situation you can notice what was there. In the inferior temporal, in the fundus photo, there's a detachment. So 1 month, though we are happy with the VMTS, but there's a detachment inferior temporally with macula on 6/9 vision. So in such a case, we have 2 options, whether going for buccal or vitrectomy. So what we did is we planned for buccal surgery. Sorry, we planned for vitrectomy. Three-port past-minor vitrectomy. So this was June 2022, and we did a 23 gauge past-minor vitrectomy.
this was just 1 month old post cataract surgery, and it's very important to counsel the patient because she's a myopic.
And the gas inside the vitreous that probably had led to extension of the peripheral vitreous detachment after the VMTS release. So there must be some peripheral tear or holes. So that led to the infratemporal retinal detachment. And PVD is very important. I did a posterior vitreous detachment in peripapillary area first, with leaving behind the, with a very meticulous protection of macula, since there was already a traction before. So this was a vitrectomy, peripheral vitrectomy, and I checked there was a holes in temporal area, and after the vitreous, meticulous peripheral vitreous saving, and since she's a diabetic also, so I would go for a near complete vitrectomy. Let's not leave any vitreous. So peripheral with indented, scleral indented vitrectomy has been done. So I identified the holes, marked it, and checked peripheral retina as well till ora serrata. So this is so important to have a peripheral vitrectomy in the high myopic patient as well as his diabetic. So it's so important to do a very, very complete vitrectomy. So this is almost towards the complete. We can see some very small holes on the peripheral retina, a very far periphery, and this was the small and next hole, which was on the attached retina. So we drain it from the equatorial region with making a retinotome, and we remove the subretinal fluid under fluid error exchange, and did endolaser retinopexy, and we kept a CTFA gas. Though it is inferior temporal retinal detachment, we didn't prefer putting silicone oil. So though inferior detachment, we still kept 20% of C3F8 gas and requested patient to have a complete 7 days face down, if possible more face down, moving forward the head for forehead. So even inferior detachment, we don't go for silicone oil, so gas also works very well. And 3 months, he had an attached retina. Visual acuity improved 6/12, and in the left eye, he's still myopic. He was a high myopic, so our plan was to left eye cataract surgery in the near future. So when we come to the pneumatic vitreolysis.
So actually this has been used very commonly for VMTs or other vitreomacular adhesions syndromes, especially
When there is a stage 2 macular hole. This really works. Almost 86%, one of the studies, 86% of treated eyes had a PVD detachment on VMTS, and closure of small macular hole, stage 2. But when it comes to the drcr.net on protocol EZ and AH, where they have utilized SAM and injection of C3F gas, there was higher incidence of retinal detachment following the augmented PVD tear. So the study was stopped in between, like 8 to 9 months later, because of more complications of pneumatic vitreolysis for the cases of diabetic VMTS. So the study was terminated and concluded that let's not go for pneumatic for diabetic VMTS. So this was a case 2. He's a 61 years old patient, and he's a non-diabetic and hypertensive, and had a history of vision blurred in left eye. His visual acuity is just hand movement in the left eye. A patient is also myopic, and he had a history of vitrectomy in the other center before coming to us. When he came to us, it was a complete vitreous hemorrhage, very suspected retinal detachment. So we planned for, since there is a total vitreous hemorrhage, after somewhere he had a vitrectomy, so I have to do it as early as possible. And this kind of vitreous hemorrhage with suspected detachment, I shouldn't wait. So I did he also had some amount of cataract. So I planned for left eye cataract surgery. So usually whenever I see a cataract, even nucleus 1 or PSC1, So I prefer doing cataract. See, patient already had an NS2 and cortical 2, so I plan for cataract surgeries combined with past plan 25 gauge past plan vitrectomy. So when, to my surprise, when I removed all the central the vitreous hemorrhage, so I could see the retina was detached, definitely. So my suspicion came true. So the detachment was temporal with a giant retinal tear, and so I prefer putting a heavy liquid PFCL. So this perfluorocarbon liquid is really helpful for whenever there is a large giant retinal tear detachment. And then I do the fluid erections, and I move to 23 gauge for the endo laser. So very nicely, I've done fluid erections under the heavy liquid, and we injected silicone oil. So this case also very important for learning, because he had a very good attachment for almost a month, but after then we also add laser. He underwent post-operative very smoothly, but after 10 weeks, nearly 2.5 months later, so we see his refraction came to be 6 by 660 with +10 under silicone oil. So everything was fine. Then we planned for silicone oil removal and vitreous wash. So after 3 months, exactly from the first our intervention, we did a vitrectomy, vitreous wash, silicone oil removal, and secondary intraocular lens implant. So vision was improved to minimal improvement, but later at 6 weeks, he again developed vitreous hemorrhage. So the hemorrhage was probably this time when we did the vitrectomy and vitreous wash, we found that there was some ischemic and some new vessels as well. So we've planned for, again, injections of Avastin for this case. So vitrectomy, vitreous wash, and fluid erections. So his vision came to be 6 by 60 after this, my second interventions. So again, after 4 months of the silicone oil removal time, he again developed vitreous hemorrhage. So this time, the patient must be very unhappy, and he must be blaming to us. So I saw that his blood pressure was very high, and he had a complete total vitreous hemorrhage. So I did ultrasound, but there was no detachment. So, but then still, in such a case, when there is a hand movement, total vitreous hemorrhage, then I have to go for, again, redo the surgery, and let's see what is being inside. So this is the 4th time, including the elsewhere who has done surgery. So this is 4th episode we are doing surgery on his retina. So this time, even after the secondary IL implantations, so we could see there's a retina was completely attached. So there was some bleeding vessels. Then we cauterized and we
Dr. Sanyam, you need to wrap up. Time is up,
CTFF gas, and we did a 360-degree barrage endo laser. So this case also came to be very fruitful, and after the 4th intervention, he had a very quiet eye. So my conclusion to the presentation is pneumatic vitreolysis can be a primary VR intervention for VMTS and stage 2 macular hole, but there is higher retinal detachment and retinal tears for diabetic VMTS, and adequate evaluation and meticulous vitrectomy for detachment management is mandatory. Thank you so much. Thank you for your patience.